Okay, so that's working, right? Okay, so I need to share my screen. Hang on a second. Okay, everyone see a presentation going on?
Yes.
Okay, thanks. Yeah, I'm not sure how much I can actually see you folks now. Hang on. That doesn't help. Okay, so this kind of just getting right into it. This is, I have a kind of a lot of slides, and we only have an hour's time here, and so we'll go through here. Hang on a second, I'm trying to get this to work. Okay. So we just kind of first start off with MHSA. I think most of you are pretty aware of what MHSA is, but I'm just going to kind of go over it, kind of try and rush through it actually, just for folks that may not be totally aware of what MHSA is. MHSA is the Mental Health Services Act. It started off as Proposition 63, which was passed in November of 2004. And it was established with a 1% tax on anyone who made over $1 million a year. So it was sometimes referred to as the millionaire's tax. Expanded public mental health care, provided opportunity to design new or adapt old mental health services. And it really was, the idea is trying to, it was an effort to try and really transform the mental health system. It was recognized that it had some shortcomings, and especially as far as funding. And so MHSA was really a kind of a grassroots effort by consumer groups, particularly, but also providers and people that were really, kind of on the front line and understanding of what the needs were. It's kind of says what I just said. Voters recognized that the publicly funded mental health services were insufficient. So I don't spend too much time on this, but the idea is also was to look at the last one there talks about whatever it takes, but it's the idea that MHSA and the mental health system could do more than just what standard mental health practices delivery that was taking place, which was largely for us funded by Medi-Cal. Medi-Cal has its federal roots and origin, and therefore its own requirements and limitations of what it can do. So MHSA was meant to supplement that system as opposed to replacing it. MHSA, according to the law, is broken into 6 general standards. I'll go through each one fairly quickly if I can. Community collaboration, which is basically saying that when we are working with our clients, we recognize that they and us are in a community, and the community also has resources that can be provided. So we should be doing that in collaboration with other entities to provide the best purposes to the client. A lot of times it's up to us, however, in mental health to kind of lead that. Cultural competency. This talks about the 9 goals for cultural competency. These I don't want to we could spend a whole training just kind of going through this one. And so I don't really want to spend much time on it, other than that, just to say that we should be addressing and working with our clients within their culture and be aware of their culture and respectful of that, recognizing that culture plays an important role in all types of treatment and approaches and working with clients. Any questions so far? Okay, well, good. Client driven. MHSA puts clients in the driver's seat. What that means is we are very client centered. MHSA really prescribes that, is that you know, we're not following the medical model as much as we are following the client centered model. Programs and services use clients' input as the main factor for planning, policies, procedures, and service delivery and evaluation. You can see that that differs very differently than the medical model, which is more about the provider prescribing what best practices and what is going to work best for that client, and really is dictating to the client as opposed to including the client. So that's a really significant one that we always should be keeping in mind. What we're doing is a collaboration with the client. They are the ones that are supposed to be directing their treatment, and their, you know, what they think is best for them as far as their goals and what they want in life, which, as I said, can contrast a lot of times with the traditional medical model. What does it look like? Client driven is inside out, working with, you know, so you start working with the client and expand from that. Outside in, which is clinically driven, is where we're prescribing to the client. All the experts and so forth on the outside are directing the client what they need to do. Client driven is individualized versus clinically driven formalistic. And the difference there is we're going to make up treatment plans that are very much based on what is the client's need and identified desires and goals that they want to work on, not what we think they should be working on, or what whatever clinical intervention we think needs to be done. Collaboration and partnership versus compliance. Compliance here means, you know, having fidelity to some clinical model. And while we should use evidence-based practices, we need to take those and individualize them for each client, so that we are working with them, that it's a partnership, that they know, not just feel and believe, but that they know that they are directing their own treatment. And sometimes that's a little tricky, as I'm sure you probably all have the experience. You know, clients will look to us as the experts a lot of times. You know, the people that have the training and experience to help them get better. And, you know, one of the challenges we have is to help them understand that they also have the ability to help themselves get better as well, help themselves recover. So that's an important conversation to have with our clients, is to help them really understand and empower them that they are the directors of their lives. Let's see, family driven. This is in there because this is, we talked about being individually driven, usually for the adult client, but family driven for children is also just as important. children in the care of their parents. The parents are making a lot of times the decisions for them, and so we as clinicians need to work with families and parents to help them feel empowered that they can help their children, that they will, just as we talked with individual adults about, that they have control and self-determination. We want to do that for families, so that they feel like as a family that they can make their choices. And so for children, often we're not just supporting the child, but we're also supporting the entire family. Wellness, recovery, and resiliency. These are definitely the hallmarks of MHSA. And based on a lot of things which I have already spoken to, but the idea is that we believe, or MHSA really believes, is that in the recovery model, in that people will progress forward if we were able to provide a context and a situation for them to improve. People will naturally want to improve. Now that recovery often is recovery is very individualized. There's no really great way to measure it other than it's working with what the client wants to be doing. Okay, the next one, recovery, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Recovery is subjective. It's driven by people's personal lived experiences of mental health challenges and wellness. Was that a question on there? Thought I heard something. I heard things. Okay. Diagnosis is not always permanent. The idea that people can get better. Care is person-focused. Outcomes include empowerment, hope, self-advocacy, choice, self-identified goals, healing, well-being, and control of symptoms. I'm hoping to get this video to work here. This is from Dr. Mark Reagans from Southern California. We actually had him up here to speak to us quite a number of years ago. Probably some of the people that have been here long might remember that. He came over and spoke to us over at the Adventist Church, just when MHSA was really getting going. And he is one of the founders of the recovery movement, which started for him started off in Southern California at what they called the Village, which was very recovery oriented intervention approach, working with consumers. So let me see if we can get this to work.
What does the recovery model look like today?
The recovery model has grown a great deal over the last 2 decades. It began as an outsider movement, began with the consumer movement, and has moved on to now be very mainstream. There's a President's Commission about the recovery movement. There's a Mental Health Services Act in California here funding the recovery movement. There's holds a number of states doing recovery movements, SAMHSA, the VA, moving along. And at this point, although it's a very scattered around the system, it is every bit as sophisticated as the standard system of care. It includes the experiences people have in recovery. It includes the relationships between the providers and the people who are receiving care. It includes who's doing the providing of care and where they're doing it, what the system looks like and what the funding looks like, what the values behind it are like. At this point, recovery is not just a set of slogans and values. It is now a very sophisticated program for how to help people with things. There's a number of people who say they're doing recovery. They put a sign on the wall and say, we're a recovery program now and do the same thing. They say, that's not different. that isn't recovery. So I think you should look for three things when you're looking for, is this really recovery? Is this really different? And the three things are, one is this person-centered instead of illness-centered? Do all of the services still have to do with treating your illness, making sure you have medication, making sure you have a diagnosis, making sure you're complying with treatment? Or do the services have to do with helping you rebuild a better life? Is all of you included there? Your strengths, your weaknesses, your hopes, dreams, your goals? Is things included about where you're going to live, where you're going to work, who can be friends, who's going to be family, what about spirituality? Or is it all just focused on the illness? Recovery programs are not just about treating an illness, they're about helping a person rebuild their whole life. Second thing to look for that's different in these programs is recovery programs move from being professionally driven to being client driven. Standard medical care, I went to medical school for a very long time. I'm very experienced. I'll give you the benefit of my experience. I'll tell you what to do and you follow my directions, and I'll check your compliance and see if your life gets better as a result. Recovery says none of us are obedient enough to do that for more than about 2 weeks. So if you're actually going to progress in recovery with a long-term serious mental illness that's affected your whole life, you're going to have to take a strong role in what's happening in your own recovery, your own treatment. Your goals are going to have to drive the process. We're going to have to do some shared decision-making. We're going to do some collaboration. Sometimes I'll be following along doing things with you I don't exactly agree with, and sometimes you'll be following along with me doing things you don't exactly agree with. It's more a partnership and a collaboration, which is real different than the standard medical model. The third thing to look for in a recovery system that's different is it really strengths-based instead of deficits-based? Do you spend all your time talking about what's wrong, what kind of symptoms, what kind of barriers, what kind of things in the way, and let's fix all of your problems and get the help by fixing problems? Or do we say, what's right about you? What are your strengths? Do you bring a strong self-esteem, a big work ethic, a belief in yourself, a good family, a spiritual background, some money along, a good place to live? What do you bring along? Because recovery is not cured. Almost all of these illnesses people have, they cannot be cured. The next psychosis is coming, the next manic episode, the next drug relapse, the next rape flashback. And the question isn't, can we make that never happen to you? The question is, can we make it so when it does happen, you're ready for it, it doesn't ruin your life. You stay held together, you don't end up in a hospital, you keep your job, you keep your family, you keep your kids, you keep your relationship, even when those things happen. Did we build the strength in you to handle your life, rather than you relied on me to fix all the wrong things with you? Those three things taken together, is it really person-centered instead of illness-centered? Is it really collaborative and client-driven instead of professional-driven? And is it really strengths-based and resiliency-driven rather than deficit-based? You should find in any true recovery program, and that's what distinguishes it from other good, compassionate medical model care.
All right.
Okay, any questions about that? That's a really good explanation by someone who knows. Okay. Skip here. Here we go. Other component, integrated service experience. This is a lot like the first one, the idea that people are getting services within the community. And there's other resources, other agencies that also can provide services. And we are working with those other agencies. And so we should be all working together to focus on the consumer and trying to meet their needs and help them in their own recovery process. And so again, you know, it probably falls on behavioral health to be the leader in that, since people with mental illness are our primary target audience there. And so with our consumers and our clients, we need to work with other agencies to help in that as it says there's seamless care. Going back to MHSA and kind of the the description of it, overall description. MHSA has 5 actually major components, and then they added 2 other here, which are also integrated within overall MHSA. But these are the areas that we receive funding for: prevention and early intervention, community service and supports, innovation, workforce education and training, capital facilities and technology. And then we also are required to have some kind of prudent reserve where we put money away for a rainy day. And then we have a small amount for the community program planning, which is the planning process that we do each year for the plan. Just real quick about that, MHSA is very supposed to be built to be very transparent to the community about what we do. Even more, it's supposed to involve the community in the planning process. So any plans we make about what we want to do with our funding, we have to run it by the community stakeholders. We have meetings all year long. A good portion of those meetings, those community stakeholder meetings, involve the planning process for the current year or the 3-year plan. When we develop a 3-year plan, we also have to do an annual update to that plan. So skip here. I just want to skip right to CSS. It represents up to 76% of our MHSA funds. So it's the largest portion of MHSA is for community services and supports. From that community service support, over half of it has to be directed toward full service partnerships. So FSP is, as you can see, a very significant program. It's not just something we do, but as far as MHSA, it represents the largest program in the largest division of MHSA. So FSP, which we're doing, is one of our primary things, is where we has the largest budget and our largest program. What is a full service partnership? It's based on SAMHSA's evidence-based practice of assertive community treatment, meaning that we are serving our clients out in the community. We're not necessarily having them come into the office for appointments, but we try and work with them for where they're at. FSP is an intensive service program for engaging individuals or families who would otherwise be at risk for homelessness, incarceration, or psychiatric inpatient services. Each FSP enrolled consumer participates in the development of a treatment plan that focuses on wellness and recovery. The treatment team is available 24/7 to provide crisis services to the client. Any questions about that? Okay. FSP services support the consumer as they transition to a lower level of care and becoming less reliant on the mental health system, which of course goes with the idea of recovery. Programs are team-based, integrating multiple disciplines of psychiatry, nursing, therapists, peer support specialists, personal service coordinators, and substance use counselors as needed. They're tied to specific outcomes. FSPs have dramatically contributed to the reductions in hospitalizations, incarcerations, and homelessness statewide. We also have evidence that is working within our county as well. The DCR, which I'll get to in a minute, which we're entering in what's happening with our consumers. we do have the outcomes and results from that. For a long time, we didn't have that, but thanks to our analyst, Patty Russell, she was able to finally figure out how to get reports from that system. And so she's produced the reports, and I think she's been in touch with almost all of you about that. But you can find her reports on our webpage and see how we're doing. FSP and partnering, which, as I've been talking about the whole time, the collaborative relationship between the county and the client, and when appropriate, the client's family, to which the county plans for and provides a full spectrum of community services so that the client can achieve the identified goals. So that's right out of Title IX. That's the regulation. That's exactly how we're supposed to be approaching our clients. Is that it's a true partnership, so that we can provide services and help them in their recovery. The next paragraph talks about that our relationship is voluntary. We can't force anyone to be an FSP. They have to be willing participants. They have to partner with us in order to be in the program. So, which kind of brings up the question, where does whatever it takes stop and partnering begins? And, because the idea is we recognize that our clients with their existing conditions may have some difficulty in partnering because of their conditions. They might forget appointments or not follow up too well, that we would prefer them to follow up. So what do we do then with this question? Doing whatever it takes, chasing them down the road to try and engage them, versus when you recognize that a client isn't partnering. That's the question I'm putting out there. Any responses to that?
Well, I know for my team that we tend to have a lot of trouble with engagement, and where staff definitely feels like they're chasing clients down. So then it kind of begins like, where do we start that drop down from FSP services because of the non-engagement?
Right.
Is kind of my biggest question and area.
Yeah, I think that is really a tough call, because this kind of what you explained right there. It's not readily apparent. There's not something that's formalistic. It really does. I think, as we've been talking about, it's individually based. You really have to kind of make that determination based on each individual case. It's not based on how much you like the client or not. It's based on their willingness to partner. Sometimes people just don't have that, I'm not going to say ability, but just don't have that desire to partner with a particular client. And sometimes it's hard to kind of tease out what the mental illness is saying and what the person's desire is saying, to try and make that determination.
I just want to add, to make things a little bit more complicated, Scott. In our world, we work with children and youth. So the parent is not necessarily the client. We work in collaboration with the parent in, identifying like the child's needs, for example, going and attending school.
Mm-hmm.
But in some situations, you know, it's a tough one because sometimes parents, because we're typically weighing, you know, are they severely, is the client severely mentally ill? In this situation, the parent is not. So at what point do we then continue doing whatever it takes for the child and then deal with the lack of partnering from parents who sometimes don't answer our calls, or, you know, in the past we've experienced in children's just doors being slammed shut on us. Like it's a tough one to balance. And I'm just curious if anyone has ideas on that.
That is really tough. It's also very heartbreaking too. Because you can see the need and you know that you can actually maybe even help. But if you know, if the parent isn't really partnering that much, that really limits our ability of what we can do. You know, and plus, you know, when you as you mentioned, you're working with the school. So the school, you know, they might be more readily, hey, this child needs help. Can you get over here and help this child and do this and do that? And meanwhile, you know, we have that pressure, and then we have the parent who's saying, no, I'm really not interested, or I'll do it every other week, or, you know, they're not as enthused as the school is about helping a particular child. And so that often, you know, we get kind of caught in the middle of that.
So I have a question that I feel like it kind of encompasses, in a way, you're gonna have to bear with me for a second, both Zabby and Crystal's comments, and also what you were saying about partnering. And it's a question I've had because I've heard a lot, well, they're not capable of partnering, so they don't meet criteria for FSP. But my understanding of FSP is we're working with people who are the most severely mentally ill, which often means psychosis, which often means extreme disorganization, which is a symptom of the disease, which does make it hard for them to partner.
Right.
And then my second, and how that ties in, I see like parents, like I have two parents I can think of who both, you know, the children is FSP, but the child is FSP because the adult, the parent, is one of our meds only like clients with a psychotic disorder. And so sometimes maybe there's the avolition or the inability to follow through on tasks they need to do, or maybe there is the disorganization where they get confused about where they're supposed to be and at what time. And so I guess for me, it's kind of like I'm struggling with this piece of like, well, they have to be able to partner, but if their symptoms are getting in the way of their ability to partner, but we're supposed to be providing them services because they're the most severe mentally ill, like I'm struggling with how we balance all that. I don't know. Big question.
It is kind of a catch-22 right there. But I do think that my opinion is that you know, the consumer, the client needs to have some ability to partner, you know, which means that they have to have at least a little bit of stability in order to do that, which is the reason, you know, why we don't typically try and partner with someone while they're in crisis, for example. You know, our crisis workers are not going to be talking about, well, let's see if we can get you to be an FSP, and would you be willing to partner, you know, when the person is actively psychotic and has no ability to understand or follow or track what you're saying. So they're, you know, the person does have to have at least a little bit of stability so they can do that. Any other thoughts on that? Okay.
So I'm sorry, what I'm hearing you say is like, are people who are like maybe need to be hospitalized, they or wouldn't be someone who's really eligible for our criteria. It's really people who are maybe have taken a couple of steps in their recovery and are at least able to say like, whoa, I got all my appointments confused. I'm reaching out to you because I totally missed something. Or
yeah, it's people that probably, you know, have at least started, you know, and started, it could be just, you know, they had to go to the hospital and are being put on some medication which helped them stabilize, so they can track and you know, follow a conversation a little better than just being actively psychotic and flirtily psychotic.
Okay, thank you. That actually helps me understand a few things. I appreciate it.
Okay, good. Oops. FSP for adults and older adults. This is about eligibility. Adult eligibility if they have a serious mental disorder, is unserved or underserved as a result of the individual's mental illness. Key things here are these three components: is at risk of homelessness, criminal justice system, incarceration, or hospitalization or institutionalization. So those three components are, probably what really separate it out of someone who's eligible for FSP as opposed to not, is that they're functioning, based on, due to their mental illness, is such that they are in danger of one of those three components. The last one, California veterans in need of mental health services and who meet the existing eligibility requirements of the section shall be provided services to the extent that resources are available. And that's true essentially with anyone. We're not necessarily serving people that have Medi-Cal for this. That's not a requirement. It's based on their mental abilities in this status right here. Although our target population is Medi-Cal, for FSP services, and actually anything seriously mentally ill, you don't necessarily have to be Medi-Cal. Does that make sense? Okay, I'll take that lack of response as yes. Older adults, a little bit, same type of things, but also experiencing a reduction in personal or community functioning. Perhaps they're more isolating, not getting out more, at risk for out-of-home care due to their mental illness, not their physical illness, not their dementia, but due to their mental illness, at risk of being placed in a nursing home due to their mental illness. Severely mentally ill. This is essentially the description of what severely mentally ill means. I want to just kind of go through that. I think you can look at this later. FSP for children and TAE. Similar to adults, but also, looking at more things that also include self-care, school functioning, family relationships, and ability to function in the community. So it's, kind of like medical necessity is just a little bit broader for children than it is for adults. So it is with FSP as well. And instead of, looking at severely mental illness, work seriously emotionally disturbed. Transition age youth and are eligible services if they meet the adult criteria, are unserved or underserved in one of the following: aging out of the child welfare system, aging out of the juvenile justice system, involved in criminal justice or the juvenile justice system, and have experienced the first episode of serious mental illness. Okay. Any questions about eligibility? I bring this up just because we might not all be making determinations of who meets FSP criteria, but we should be aware of them, particularly because, when we, not only for people that we might want to refer to this for an FSP, but also as people are graduating from being an FSP, because you're going to be looking at, do they still meet the eligibility criteria to be an FSP?
So I want to add to that too, Scott. And we run into this in children's even without FSP. I know that the scope is pretty wide, right? So a lot of folks can be eligible. So at what point do we balance between that and capacity?
Well, you know, the thing about MHSA is that it's supposed to be applicable to everyone. And you know, so we really need to, but you know, also resources can be limited as well. So you have to, you really do have to kind of balance that. You know, if there's a way we can provide treatment that doesn't require the intensive level as an FSP, but it will still be successful, then we should do that. You know, we always strive to be the least amount of invasive as we can, you know, provide the lowest level of services that a client can take and still be successful. And that includes FSP as well. You know, not everyone, I mean, they might be having some severely emotionally disturbed, but it doesn't necessarily mean that they would successfully or need to have the level of intensive services as an FSP to be successful in their recovery. Does that make sense?
I want to say yes and no.
Okay.
Just because, I mean, okay, so what I got from you was that basically a lot of people can qualify, right? And considering that we have very limited resources to try to see what we can provide without having to commit to providing full-blown FSP where it's, you know, coordinating for them and, you know, being the only linking source for them, which is, I guess, my concern, just because.
Yeah. Well, you know, you know that we're always supposed to be able to provide services where the client is at, and also we're supposed to be, you know, be the least invasive, and you know, so we're not sticking people in institutions that don't need to be in institutions. We're not, you know, providing, you know, the highest level of care for everyone because it doesn't fit. FSP is a relatively high level of care, and if it's you know, overkill, then you know, like it's like institutionalization. We're not going to do that. What we want to do is provide, you know, the services for our clients to meet them where they're at, so that we can help them be successful with the least amount of invasiveness as possible.
Okay, thank you.
Here's a little bit more about eligibility criteria. Individuals who would be at risk for homelessness if they did not have families caring for them. This is true for many clients from ethnic communities. Board and care homes are considered institutions, and those residing in them meet priority population FSP criteria. So we have a couple board and care homes in our community. So the people there can be FSPs. They can't be FSPs if they're in board of cares outside of our county, because we're not able to provide the level of services that they need. But within county, because we can go out and visit them, they can. People meet access for criteria to an FSP at various levels of recovery. They do not need to enter into the highest level or need service intensity, which is a little bit what I was just kind of saying this previously. Economic status should not be consideration to meet criteria, which I mentioned previously. And an individual service plan is where clinicians outline how they are meeting services criteria for FSP, including 24/7 care, personal service coordination, and client-driven. This will look different depending on the level of client recovery. So just kind of a quick thing about that last one right there that was kind of mentioned. One of the requirements for FSP is to have an individual service plan, which is supposed to do with those what it says right there: 24/7 care, personal service coordination, and client driven. We have chosen not to do a formal individual service plan for FSP. However, we should be including those elements in our treatment plan for FSPs, so that we are still following the regulation and criteria for what we're supposed to be doing with FSP. Okay. So our individual service plan is our treatment plan, but we need to, within that treatment plan, cover these elements. FSP services include a full spectrum of community services, everything that we can offer, which is listed right here. Our FSPs have that ability. FSP, technically it's supposed to be, akin to wraparound services, especially when someone first enters into the program. I know that's with our limited resources and staffing issues, that's not always the case. Maybe that's even overstating it, but we need to do, as best we can. And the thing that kind of goes with that is, I think this, for us is making sure, especially during a pandemic, that if we're just reaching out and having contact, just checking in with our clients, just to make sure that they're okay and see if there's anything that we can do, then we should be trying to do that. We're not going to be able to provide a perfect wraparound system, but we should try and do our best. And we can also, try and, as I mentioned earlier, it doesn't just have to be us either. If we can get our community partners to also be working with our clients, so that it's not just us that's doing it. It's also, really want to emphasize, we have our wellness centers and our peer support that can offer a lot, and it's helping our clients, use those resources. We have that resources all around the lake, and they're available for anyone. And they're doing some really good stuff at those centers, including support groups and just someone to talk to, some place to go, and have something to do. So please really, try and get our clients to recognize that resource and be able to use it, even if they need transportation to get to it, because it's something that we can do, and it's there, and it's not going to require a whole lot, from our treatment staff's time to do that. Any comments about this? Okay. One thing that's, and I know take this a little bit for granted, but supports need to be available 24/7. So that means that our crisis team is part of this. Technically, our consumers are supposed to know who their support team is. Our support team includes our crisis staff, and so I think it's good just to kind of, if you can't, introduce our crisis staff to your clients, at least tell them, who is our staff that is on our crisis team, in case that they might feel more comfortable to calling them if they need to after hours. FSP services, non-mental health, non-medical services. So, these are things that Medi-Cal does not cover, that MHSA and FSP can cover, which is food, clothing, housing, healthcare treatment, substance abuse treatment or co-occurring conditions, respite care, and any kind of wraparound. So it's, things that, like I said, are supposed to supplement, not replace, traditional Medi-Cal services. FSP expenditures for clients. You probably, I think we do this we do this a lot better than we used to. I think we do pretty good, actually. I know Axel does a lot of reminders, but we need to have budgets for FSP clients that we do at least quarterly, or unless there's some kind of change, more than that. And use the MHSA funding request system, which I think we're all doing great on, as far as I can tell. FSP data collection and reporting, the DCR. So I mentioned earlier, this is also a requirement that the state has put in for FSPs, recognizing that the FSP programs are some of our biggest and most important programs across the state that address those that are the most vulnerable and the most ill. And so the state has naturally wanted to get reports on how people are doing, and so have the data collection and reporting system that they use to also report statewide of how things are going. The DCR is not a perfect system by any means. They're trying to improve it continuously. I know it took this even for a long time, even for the state to even answer questions about it. And so, but I think they're doing a little bit better now, since the California Directors Association has kind of gotten after the state about that, because a lot of the counties were complaining. Which, you know, because of that, we weren't able to get reports out of our system. And yeah, like I mentioned, Patty was able to figure that out. So the DCR is made up of three major reports, starting with the PAF, the Partnership Assessment Form, which are kind of putting in the baseline data for how people are doing. The second one is the quarterly assessment, which each quarter you're just answering questions about how the person is doing every 3 months. And then the third one is the key event tracking, or KET, which you use in between quarterly reports if there's any changes, you know, based on administrative information, which can include, you know, demographics and you know, residential, education, employment, legal issues, and emergency interventions such as hospitalization. If someone's hospitalized, we should do a KET on that. If they move to a different apartment or step down to a lower level of care, we should do a KET for that. Okay. The FSP process starts with assessment. And if they don't meet criteria for the FSP, or just don't meet the criteria in general for mental health services, they're referred out. If they do meet criteria, and we think that they do meet FSP criteria, not just medical necessity, but FSP criteria, we refer them to a central person who makes that determination. We want to have one central person doing that, this consistency across our program. You know, for those that are in the program, that they meet FSP criteria. Right now, Ronnie used to do that, and I think James is
Right now, it's me.
It's James. Thanks, James. Thanks for affirming that.
Yeah, have it go through the team leader, please.
Yes.
And then to me, that'd be great.
Okay, perfect. And if James determines that they do not meet criteria, they're referred elsewhere. If they are, and then you do a PAF. Part of that process is you communicate with Patty, who's our analyst, so she can set them up within the DCR, so you can do a PAF. And then you'll do a quarterly every 3 months after that. And then, as I mentioned before, you do KETs in between. Questions about that? Okay. FSP meetings. Everyone's doing FSP meetings, right? Hope at least we're doing some meetings, because that's really where the work is happening a lot, or at least the planning for the work is happening with our clients. You know, where we're meeting with them to determine, you know, not only just, you know, do a treatment plan or individual service plan, but also, you know, we're following up every 3 months to see how they're progressing with that plan, and how, you know, how services are going, what tweaks need to be made to get things back on track if they've gone off track slightly. Maybe it's doing we have them when we run into some barrier, such as you know, in housing, or you know, something that's going on that we need to have an FSP meeting to really, you know, talk to the client, to, you know, really take a look at what's, you know, there's something that's an issue that we need to solve. So it's a really important meeting. It's part of the regulation of what we're supposed to be doing with FSPs, so it's a requirement. But it's also, you know, it's a good tool to use to work with clients. FSP housing. Obviously, that's a big part of FSP for what we do, because so many of our folks, due to their mental illness, don't have housing, or have lost their housing, or not eligible for housing, or can't afford housing, or, you know, well, afford, it's not really, it can't afford due to their mental illness. It all ties back to their functioning, and their functioning is getting in the way of them getting housing. And so we have the ability to assist with that. We also have the ability to do that with well, I'll get to it, I was going to say with children as well, but I'll get to that in a second. Types of housing. MHSA can pay for emergency or one-time housing assistance, and that's for like when we have someone in crisis and we need to put them in a motel for the night, or they're getting out of the hospital and they need something as they're exiting the hospital. Those are, we use the MHSA program of the crisis continuum of care to support that. Otherwise, for both transitional housing, which is for what we use right now, is motels, and permanent supportive housing, which is where we are, you know, helping pay for a client to stay in an apartment and subsidizing their rent. So those last two types of housing are paid for by FSP. FSP funds pay for housing clients and families. Families include parents of FSP children and minor children of FSP clients. So if we have a child who's FSP and due to circumstances they're having housing problems, facing homelessness, then we can support housing for that family. Budget should reflect contributions of other family members. FSP clients in permanent supportive housing need to have a payee. We have that as a requirement, that last one there, because we've had lots of issues where we are partnering with a client and they decide not to pay their rent. And so that creates problems for them when they do that. And so therefore we're asking them to have a payee. There is exceptions for that that you can make if you really feel that the client has the ability to manage their funding without a payee, then you can make that case that functioning level is exists. Okay, any questions about that?
So we had some clients that we know that they haven't been able to manage their finances, but absolutely refuse to get a payee.
Well, and that's the tricky part right there, you know, because we're for a client to be successful, that is not going to lead to their success. And so that's where you have to, you know, kind of really use some of that motivational interviewing to help them see the need for getting a payee. And it's not just because we're telling them to, but it's something that's going to help them long term. Again, you still might have people refuse to do that, and then you're going to have to make that determination. Well, you know, if you're not going to be willing to, you know, help yourself in this, then it kind of puts us in a bind of us being able to help you as well. So again, everything's individually based, and so you're going to have to handle that on a case by case.
Okay. And then another question is, by permanent supportive housing, like if we have the FSP client, they are stable, they are doing well, and really we get to that point of all that we're really doing is paying rent, because they can't afford it on their own, and it takes so long to get into low-income housing.
Right. Well, let's get that. Let me get that. I recognize that, and I've thought of that, and so but you're stepping ahead just slightly.
Okay.
And I got to hurry up because we're sliding out of time too.
Okay.
This is real quick here. This is for FSP housing, what Axel does on the left, and what his role is, and versus what case managers and SAIs do. I don't want to get into this because we're again running out of time, and I really want to address what was previously just mentioned here. Okay. And this kind of ties into that, what we're talking about. So how does someone graduate being an FSP? Where do you graduate them to? There's barriers to graduation, as just mentioned about housing. And so we have something we informally call FSP Light, which recognizing that, you know, and this ties along just in general with how we approach services, whether you're an FSP or not, is this, you know, usually when someone enters services for mental health, is we give them a lot of services up front. And then gradually we pull back as they're in the recovery. They're not as dependent on what we provide. And, you know, eventually we pull out enough that they graduate. And FSP is the same thing. You might start off very intense, more wraparound type of services, maybe a lot of financial supports. But then the idea is it eventually gets less and less. The reality is, though, you know, we're stuck with the housing problems that we have in Lake County, lack of affordable housing, and you know, paying for rent. If we didn't pay for rent, they're not going to be able to afford rent. They'll end up homeless again, and probably right back in our system because not having a place to live. So it behooves us to keep funding their housing so that they're not deteriorating and ending up back in harm's way again. So ideally, what we want to keep with those folks is, you know, keep applying to low-income housing, keep applying to the low-income apartments so they can get into some place that we're not subsidizing any longer. And this is why our Bevins apartments are such a great resource. We're getting, as Todd's mentioned, we're getting another resource in Nice, which will be it's a 40-unit apartment complex, and our clients, we will get 20 of those 40 will be for our clients. And so I think right now we are subsidizing around 30 some clients.
Hey, this is Melissa from County.
And so that would help out a lot of them if we, when we get that. So, in the
All right,
meantime,
Melissa, can you please mute your computer? Melissa, please mute. Thank you.
thank you.
Sorry.
I can't see when I have the screen like this, I can't see who's talking or not. So thank you for helping me there. Any kind of questions on what I was just talking about or comments? Okay, obviously people can exit FSP by withdrawing or moving away. And they can also do it by not partnering. And we started talking a little bit about that where, someone, whatever is going on in their life, have decided not to continue partnering with us, like the County Behavioral Health. We're a voluntary program. We can't force anyone. We can keep trying to cajole them and use motivational interviewing. But ultimately, it's going to be their choice. Sometimes people just kind of disappear and we can't find them. And so we have to kind of make that decision that they're not partnering. And so anytime we do that, because that's a unilateral decision, always make sure you send out an NOABD for that, because we're giving them, either exiting from services or maybe a reduction in services to meds only. Or we're not able to provide housing for them because they're not participating. Always make sure you do that NOABD when you are reducing or changing services, not in a partnering way, not where you both agree that, okay, we're gonna drop your services, but in a way that where we're making that decision based on their activity. Okay. Okay, any other questions?
So what about if they're in housing, we're paying subsidies, but they're not participating at all?
Well, that's where we have to give them notice. We have to work with them, help them understand, hey, if you're not going to partner with us, we can't continue to pay for your housing.
Okay. And that's what we do. We call it kind of that come to Jesus talk.
Mm-hmm. Right.
Okay. So
It usually works, but when it doesn't, and it sometimes doesn't, then we have to give them full notification that we are, that's what the NOABD comes in, that we're going to be, dropping that service, and they will be on their own.
Okay.
Which is really unfortunate when that happens, because usually what happens is they'll get evicted and be homeless and end up back in our system again, starting from scratch.
Okay. I just wanted to make sure we were kind of doing that correctly.
Yeah. Any other comments?
Scott, this is Irvin.
Okay.
Yeah, thank you so much. Very informative. You explain things so well. So a big question, of course, is when we do terminate services, first thing is to have a good contract to begin with. And as in my various discussions, our form is very vague and partnering, it's all, so these details really need to be specified with each client. And so I would just put that in there. Perhaps we can have a more definitive form, or, so that it's clear what the client knows what's expected of them, and what they're also, when they're being terminated, what standards they specifically are not coming to.
That's a great point, Irvin. That's where that FSP meeting is really important to be able to do that. That's where you do that initial treatment planning, really defining roles of who's going to do what and what each person's going to do. And then you have that agreement right there. And of course, you know, in the treatment planning, they're coming up with ideas and things too. And so it's because we're very, you know, client centered. It's not just us writing a plan and here you go, agree to it. You know, they have to, you know, really are participants. And when you're participating, you're much more likely to follow it and then have something given to you. So, you know, just making sure that, you know, you're doing that collaboration right up front, which really buys in their participation, you're probably much more likely to have success from that. And then, you know, follow-up FSP meetings, this we kind of, you know, making sure everything's going okay, going through the plan again, everything's looking good, this is working, this is not working, what do we need to do? Just so it's always, you know, the topic of discussion of how things are going, what's working and not working. So, you know, hopefully by the time the person is exiting the system, it's not a big surprise. Either they are exiting successfully or, you know, or unsuccessfully, but they've had full knowledge that this was coming based on previous discussions. Okay. Anything else?
I'm just wondering if I can get a copy of the slides, please, for
Sure.
future reference. Thank you.
You bet. We can do that. I'm gonna stop sharing. We can do that. Well, is there anything else? Okay, well, thanks for your time. I just want to let you know that I'm always available if you have a question about FSPs or MHSA in general. And one more thing I'd like you to keep in mind is we are, you know, I mentioned previously that we're having an MHSA stakeholder meeting. We do those all the time, and we're starting a new series of, you know, for our next plan update for 22-23, and that meeting is going to be on the 24th. And so if you would like to attend that, it's a couple hours from 10 a.m. I think Patty's been sending out invitations to that. So that'd be a good thing to go to, because we'll go through MHSA in general and also start hear the community what they think we should be doing. Okay.
Scott, can I say a couple things?
You bet.
First, I want to thank you. This was awesome. I really appreciate it. Saved my voice. Because you know that I've done this once or twice. Mm-hmm. To the clinical leadership, what are we calling you now? The supervisors, the clinical supervisors. We'll be meeting at this time again next week. So 11 to 12. That's it. Everybody else, thank you for coming.
Good seeing you, James. And thanks for being here, and thanks for the questions. I really appreciate the discussion that you have and the interest that you're taking. So again, I'm always available, and take care. Bye-bye.